Good morning, everyone. Welcome to Public Health and Epidemiology Sciences Plenary Session. I'm pleased to introduce Dr. Sean Rourke, who is plenary speaker for Public Health and Epidemiology Sciences Plenary. Dr. Rourke is a clinical neuropsychologist and professor of psychiatry at University of Toronto, and he is scientist at the Centers for Urban Health Solutions at St. Michael's Hospital. He's also director of two centers, CAHR Center for Reach and HIV/AIDS and CAHR Community-Based Research Collaboration Center for HIV. Sean is transforming how program science and community-based research can be used to have stronger impact on policies and frontline services and to solve complex health problems for people living with or at risk for HIV/AIDS. With his novel, effective approach to community stakeholder engagement, partnership development across disciplines and sectors, innovative KTE, and research to action strategies, Sean is having a major influence in getting us closer to the HIV epidemic in Canada.
If you have not yet downloaded the app, please do so. Dr. Rourke will be including some polling questions within his presentation that ask you to vote via the app. So instructions are on the screen. Once you have the app downloaded, open the Sean Rourke session in the Program tab. So let's welcome Dr. Sean Rourke.
Thank you very much. It's a pleasure to be here. I guess before I get started, I just want to say, I look out in the audience and see this incredible community of people that are so committed to the end of the epidemic. Just talking to Malcolm King and talking about what's happening in other areas and his own work, and really, his comment was how well we're connected and how much we work together, and it's really the strength that we have. And I think even before I give my talk, I just want to emphasize three main messages today. In fact, and I think they're really important ones. One is that we have all of the expertise we need to end the epidemic. It's all here in this room. It's all each and every one of you. I'll say it again, it's each and every one of you. If we actually bring that expertise together, and the second thing is, with all the knowledge and tools that we have, I can't tell you as a researcher how much I see studies, come in over my desk, systematic reviews. I can't even keep track of those anymore. There's just so much volume of work. We actually know the answers. The third thing is leadership and action. That we really need to take a leadership role as a community and end the epidemic. And in fact, I would put to all of you to think about as I go through my slides and my talk. And that is today, Friday, January the 27th. January 27th? April the 27th. Let's get it right. Let's make today the first day that we actually end the epidemic by 2025, because that's what my talk's about. So it's really, I put it all to you, because the expertise is here. We can do this. I have no conflict of interest. I just want to acknowledge in Toronto, I'm very fortunate just to acknowledge the lands of the Mississaugas of New Credit and the ancestral and traditional lands of the Anishinaabe, the Ojibwe, and the Huron First Nations where I work, and certainly recognizing lands here today. And I really want to dedicate this talk to the people who actually, I'm here today, over 25 years of working in this field because of a lot of extraordinary, incredibly passionate people. And Positive Spaces, Healthy Places, you're not going to hear about today. I'd love to talk about it, CAHR funded. But these are the people who actually made a huge difference, and they're not with us anymore, and this talk is dedicated to all of them. So my outline, and my slides are really a backdrop. If you've ever heard a talk from me, I always have too many. And really the message today is what can we do? So I'm going to talk to you about an initiative that I've been involved with as part of the CANFAR Board of Directors for the last couple of years, and tell you where we are with that today. I think it has a lot of effort and energy and enthusiasm to move to the next step. And we're going to talk about 4 goals. And part of the polling is actually get a sense for where do you think these 4 goals fit in ending the epidemic. And we'll end with the leadership and call to action. And just to highlight, we can do better. I mean, we have, over the next couple of days, there's going to be incredible research that's presented. But we have, again, all the knowledge that we need to do this. And we need to, as a country, really band together and really move this forward. I'm concerned about the lack of urgency that we don't have anymore about this. And I think that's something that I'd like everyone to reflect on, and certainly I'll come back to. So what are the numbers? You all know them. And by the way, I'm not an epidemiologist, so I'm not going to go heavy into numbers today, but you all know these. And the epidemic is not changing. Hepatitis C is really still out of control, and STIs, these are numbers from 2012. These are just not numbers that really speak to feeling good about where we are with these epidemics. And the targets, it's great to see us commit to targets. It's great to see us think about cascades. It's great to see us think about how we're doing in all this, and I'm going to show you a bit of data on this, but there are a lot of people that are undiagnosed. And I think one of my messages today is we're not doing enough at all to get to the undiagnosed that have HIV, hepatitis C, and other STIs. And here's a slide to really emphasize that. There's over 12,000 people with HIV that are estimated. It's at 20%. The numbers may have gone down a bit, but it's still unacceptably high, and so we need to do something. And we all get, as researchers, we write statements like this that I pulled from a PHAC document about what we need to do. Again, this is about action. It's about thinking about what we're not doing and what we can do to make a difference. So, first polling question, for those who actually have their app, how would you rank Canada's performance of getting to zero compared to other countries? A, B, or C? And the winner is? How long does it take? Oh. Average, okay. Well, 27 votes, they're coming in, okay. All right, here we go. I've never done this before, so it's working, so that's good to see. And thank you for CAHR for helping arrange this. So we'll just wait another 15 seconds. I think the numbers can still come in because we'll get final numbers. We'll share these with everyone, by the way, after the talk. All right, so I think it looks like most people feel that we're sort of average in our response. Can I move back to my slides, please, and let it continue? Thank you. Okay, one thing is helpful to know, because we're such a diverse group, is where you come from. How do you identify with? And this is not a skill testing question. I'm not a qualitative researcher. I wrote this just to get a sense of, just please check off who you identify most with in your day-to-day week. And by the way, as we're doing this, the next set of polling questions, which is just only 3 more, they're at the very end. So. Okay, great. Thank you. Can we move on, please? Thank you. So this is a publication just 2 years old. Canada is missing on the map. Now, there's a lot of effort going on the Cascade, and I actually think we're doing a pretty good job, and I'll come to that in a moment. But, we're missing. And so average and missing, we still need to do more. A lot of optimism about slogans, about messages, and these are great, but they're only so good as what we do to reach them. And so, it's a big thing for me that I feel that we really don't, we haven't actually set targets and thought about what are our business plans to get there. So this is something we need to do. It's great to see Dr. Philpott and Dr. Tam commit on World AIDS Day last year and this year, or just recently, a commitment on the targets, a commitment with Dr. Tam about preventing new infections, about increasing testing, achieving better health outcomes for people living with HIV. And in there, working with public health to make sure public health messages like U equals U are actually out there in the mainstream. So this is great to see. And as you know, there's a framework being developed, and this is where our work at CAHR sort of intersects. We got ourselves going and then realized that this was coming online as well. So we sort of stepped back and figured out where we could position. And it was interesting to see, so this is still ongoing, and I'll say that it's still ongoing because it started in 2016. I was part of the group that was looking at how to frame this, and there's a number of people in the room that were part of this as well. At the bottom, I looked at the PAHR's website to see that they're committed to getting the infection rate down, incidence, in 2030 by 0.6 cases per 100,000. That's 12 years away. That's too long, and we need a plan. I do think we can get there sooner. Leading Together. This was a fabulous document that was written. So much effort and consultation that went into it. I was so excited about this when it came online that I signed up for the co-chair. So I was there for a good couple of years, but it failed. It failed. This whole effort failed. It had everything, it had all the right words, it had all the right things, it had all the right, things that we could do, but it failed because of leadership. And at the time, nobody wanted to commit to targets because that meant resources. And so this is something that we struggle with, but you can't solve things unless you have resources, unless you have targets. The one thing that I'm a bit concerned about as well is that if we're going to have real life impact, it's not me at the microphone, it's the community. And there aren't a lot, we're not on the front page anymore. I don't, coming to the conference, I talked to a lot of people about the efforts that were underway, and there's excitement about doing something, but we need to get back at the microphone and make sure that we're speaking loud and clear about what we need to do and committing to that. And here's a quote for Yogi Berra: if you don't know where you're going, you might wind up somewhere else, someplace else, and it's true. However, places like the US have done an exceptional job with setting targets with their strategy, really doing modeling studies to understand how to achieve an incidence rate of X. When they don't get there, what the kind of SWOT analysis that they can do. There's paper after paper that come out every week about where they are with their strategy. And other countries are doing the same, but it's really something that it is about targets and benefits and cost effectiveness of making decisions. So turning now to our fourth decade document, this is a really, I think, a nice piece of work that we did a couple of years ago, really as a white paper to get people engaged or excited about the possibilities of ending the epidemic. And it's available for people now on the CAHR website, as well as it'll be linked with CAHR. But it lays out just our recommendations on what we need to do to achieve targets. And the working group that we formed, again, as I circle back to Dr. Tam, as the STBBI framework was coming online, we didn't want to compete with that, so we asked her, what can we do? Well, she said, why don't you develop or identify what are the research strategies that we need to do to fit into this framework? So we said, sure, we'll start that. We have Bill Flanagan, the Dean and Professor of Law at Queen's, chairing this. We have a fabulous group of people from across the country, clinicians, researchers, community folks, public health, and people, sorry, Stan Reed should be on this list as well. Sorry, Stan. And put this group together to then think about, well, where are we? What are the priorities? But what we did and recognized very, very quickly was that, you know what, we can develop priorities, but we were just struck by how much we already know. And so this is now what I'm going to share with you about what we've identified as some of those challenges and where we think action should be in these four main goals. Leonardo da Vinci, here's a great quote, I think, that really highlights, I think our mindset. This isn't about thinking, it's about doing, about applying and moving things forward. So here are the challenges that we think remain. And people can argue that there's a few others that are missing on that. But again, if you look at prevention, care, and treatment, these are the challenges that we all, I think, would agree on, 90%. This is what is still affecting us in getting the end of the epidemic. But we have the tools. We know and we hear about point-of-care testing and self-testing and PrEP and PEP and U equals U and treatment as prevention. All these things are really effective prevention public health interventions. And we're not doing enough of them. We're not scaling. We're a country of pilot projects. We're a country of having great people do great things, not scaling them. Scaling them is so important. And we hear about that from other places, that when you scale, things go down. They don't go down right away, but you got to give them a little lead time, and they will go down. So in terms of program science, or implementation science, this is nothing really new in a lot of ways, but it really is thinking about just being pragmatic, really about thinking about what are the right things you do in the right place for the right people, the right time, the right scale and efficiency. So this is the sort of context that we think we need to be operating within. And so this is our vision that we've put forward, that Canada ends the epidemic by 2025. And to end that, we need to sharpen our focus and efforts. We need to set goals and targets to measure our progress and our success, and when we fail, what we're going to do about it. And we implement and scale up coordinated solutions in prevention, testing, care, treatment, and stigma reduction. It's hard to argue that, right? So what are the four goals? I'm going to run through these, and then we'll have some time for questions. Prevention, unacceptably high incidence rates in certain priority populations. And certainly we need to know there's much more testing and prevention efforts that need to happen. So here are the key actions that we're recommending. Again, you can argue there's more. We're trying to have a laundry list of all kinds of things. Probably the first three are ones that we can do right away. Some of these other ones, I guess, structural barriers are difficult, have to have broader communities of people working together. But clearly scaling up combination prevention, harm reduction, health promotional messages, these things, testing, PrEP and PEP, are things that we think very strongly about that need to be scaled. Testing. 1 in 5 people are still undiagnosed. Not enough, again, scaling of messages around those issues. And just as I'm writing, a lot of things happened as I was preparing for this talk, but Australia just has some very nice data from the Kirby Institute showing that in the top two, showing that it's the undiagnosed that is driving the epidemic in gay men. They've gone from an incidence rate for undiagnosed from 15% to 7.5% in the last 10 years. And so this is clearly, and there's other countries that are doing analyses like this. We need data to understand where we are and where we need to go. I just want to applaud the work that's happened, and I'm going to show just a few examples of those, of documents that have said, okay, how do we reach the undiagnosed? What are the priorities and directions? And so Katie's done some nice work here. We have Jackie Gahagan, who's done some very nice work with understanding point-of-care testing, where we are, and what are the key actions opportunities. And I'll highlight, we're never going to get point-of-care testing scaled up in Canada unless we deal with the billing issue. And the second thing is industry, they're not coming. They're not coming. They're not bringing their tests. They're not wanting to do the work in Canada. Why? Because there's no market. 6% of tests are point-of-care in Canada versus 58% in the US. It's just unacceptable. Here's an example of that from Biolytical, showing that Canada's actually gone down in how many point-of-care testing we've used. They have 6 available in the US. And here's a nice report that Sarah Fielden and Mark Gilbert did a few years ago here in BC, showing that showing how well point-of-care did in the left, in the red there, how well it did in picking out the positivity rates, and picked up 30% of people who are undiagnosed, but it was only 5% of the testing overall. Quite remarkable results. Self-testing, again, Canada is not on the map. And this is increasing just doubling the amount of self-tests that are available worldwide. And self-testing offers a lot of options. Point of care is one, self-testing, dry blood spots is another. There's promises and certainly obstacles or concerns. These are all manageable. It's all things that we can deal with. And I won't go into them today, but again, the obstacle is really leadership to get self-testing options available to people here in Canada. The regulatory folks at Health Canada are doing a good job with setting parameters around this. There's a new initiative coming out in 2019 on how they'll be able to have options for not having the data only collected in Canada, that will use data from other countries. This is a positive step in the right direction. Again, but if industry doesn't want to come and work with us, we're never going to get there. One size doesn't fit all for testing. We need, as we all know, we need options for people, and there's a variety of those. And again, there's lots of work going on to build initiatives, of capacity and awareness and education on this. Again, we need to take action. And the evidence, I could have 10 slides of all the evidence on point of care and testing options, from the ease of use of these, to the widespread support for them, to the cost effectiveness of them, to the use of them in emergency departments, here in Vancouver as one example, and what social marketing techniques can be used to actually get these tools and these testing available to people. Why aren't we doing this? We're doing some of it, we're not scaling. So here are the actions for testing. And the first 6 are all very important, and we need to focus a lot of them. Promote testing, expand innovation approaches, awareness, or access, I should say, to point of care and provide it in more settings. We're very limited in the settings that are available. Make them affordable, and when they're not, subsidize them. This is happening around the world. Set targets for what is the target that we want for testing to reach populations, party populations in different places around the country. The next thing I'll mention just quickly around the health outcomes piece. This is very important around the cascade. We are actually making ground here, I think, and there's still far too many people that are being diagnosed late. But there's lots of great work happening, and actually, in fact, so this is just examples from Ontario, Alberta, and BC. Just as I'm doing work preparing for this talk, Vivian had a paper looking at when BC is going to reach 95, 95, 95. This is exciting. But we also have to realize that there's cost available, a cost associated with this. And this is nice work from John Gill in Alberta, showing that reaching the undiagnosed and getting people suppressed costs money. So these are balancing acts that we have to also keep in mind. Here are the actions, and these are principally actions around health ministries that will do this, but you know, these are key actions that we're recommending. Finally, stigma. Stigma continues to be a major factor, a #1 issue for people living with HIV in Canada, and it creates barriers for health access, for services, seeking support. And there's a number of solutions for that, both on the policy side, but also just normalizing things that happen day to day, like testing, and education, but not just education for the sake of it, but education that changes not just attitudes, but behaviors. We've been fortunate to get some money to support this nationally, and we have a great campaign that's going to be starting really soon. I don't have time to show you this promotional video here, but for those, this will be online. People can click on and see it. But it really is about changing the conversation around stigma and about resilience and about how people are seeing this through and what we can do to obviously address these issues and these barriers and what happens in different environments. But I do think that the conversation is one, and many community groups are now starting to use social media for stigma campaigns, which is great to see, and we need to scale those up. The last thing I'll say in terms of these goals is just that they're great, but we're not going to do unless our community here in Canada comes together. This is the way we work. People living with HIV and affected are at the center, need to be at the center of these efforts. They need to be at the microphone. They need to be saying, this is what we're going to do. Here's how we're going to do it. Obviously, it needs to be grounded in social justice and health equity. And we work well together, actually, you know, all of us in the room. And we need to continue doing that, and that'll get us there. So, polling question number 3. What is the most important goal for us right now in getting to zero? And you get to pick one of those 4. This is sort of what we expected to see, fighting out number 1 and 2. Not that I pushed you a little bit in that direction, but a little bias there. Should acknowledge that. I've got to figure out in my own head. Now it's... All right, can I have my slides back, please? Thank you for doing that. That's now up to me. What is the greatest barrier for getting to zero? There's a list of, pick one. There's actually, we had trouble actually with polling. We want people to rank 1, 2, and 3. We couldn't do that. So pick the one that's most important, you feel is the most important here. Thanks for that. Can we go back? Just want to try to end on time so we have a few minutes for questions. Critical factor clearly in my talk today is leadership. And again, just to emphasize, I've said these things already, but this is our opportunity. This is our chance, actually, as a community of people who are supporting everyone living with HIV in Canada and ending the epidemic. If we do these things, if we create a sense of urgency, if we actually build it well and get people at the front end of this, leading this, we will get there. Complacency is a silent killer. There's too much of that going on. This is the last question. Do we have the evidence? Do we have the knowledge? We have the evidence. We have the knowledge. We have the tools. But do we have the will? What do you think? Can we do it? Look at that, nice bell curve. That's great. Nice even, wow, we get using the full range of the scale, as they say in CAHR. Thank you. Back to my slides. So possibly, seems like we have some work to do to figure out how to move people. Again, as where I started and where I'm going to end, and I have 2 slides after this. This is a call to action for everyone. Today is April the 27th, Friday, day 1 of ending the epidemic of 2025. And is the will in the room? Possibly. I think we need to do better than that, guys. Really, seriously. So what if? What can we do? There's lots that we can do. And I'm not going to answer that, and I'll end with this. When you come to a fork in the road, take it. Thank you. So I think we have a few minutes for questions. I think there's microphones that are going to be around the room. Yes, Andrew. You need a microphone. I will not be able to hear you from there. Just 1 sec, Andrew. You don't want to lose your what you're saying, please. Can't hear yet.
I'm wondering, Sean, if you feel that the limit of 80 scholarships for people who are HIV positive to have registration waivers for this conference helps or harms our ability to end the epidemic in the timeline you present?
I think it's a great question about how we continue to have engagement at these kind of events, but I should say these events are just milestones along the way. So 80, I'm not sure, Andrew, what the right number is. 80 sounds like a good number. Could it be more? I'm sure it could, or maybe people want to advocate that it should be more. I don't know the answer to the right number. But what I would say, though, is that we want engagement across the year, and how we do that and how we keep people engaged in conversations and movement and who's at the mic all through the year is important. So it's even broader than that. So keep up advocating, Andrew, for making sure that that voice is there loud and clear. Yes.
Hi, thanks for a great presentation. My name is Sylvia Guglielmi. I work here in Vancouver. You gave a general impression of what's happening in Canada, but certainly, as you are aware, each province has different policies and budgets and in terms of the management of HIV. So certainly, each province has managed this issue in a different way. But one of the things I didn't hear in this presentation is the issue regarding Aboriginal peoples of Canada. And when we look at the numbers, probably that's where the most affected people in terms of lack of diagnosis, access to care, and treatment. And I wonder how you will incorporate that in your presentation.
Yeah, great question. I was talking really in very broad brushstrokes. We all have different things that happen in the provinces, and there's this challenge too with FTP, with the government, the federal government, not wanting to impinge on provincial matters, but also promote public health. So it's a balancing act, I think. But I think the important message, though, is the priorities and making sure they're right out front, and the actions. I mean, I still don't think that there's enough conversations about pushing the field forward that we need to have and advocating for those who need them the most. BC does it very well, and there are other places across the country that do it well, but we need to do this. I mean, I think there's lots of lessons learned from each of we're all very strong in our emotions about this, but we're not unified, I think, in how we do this together. And I think there's lots of lessons learned that can be shared that we don't share. And I think we should help to facilitate those more. Again, scaling and sustainability is such important that we don't really talk about. We're very good at funding individual studies. Ron.
Thanks very much, Sean. And just in terms of full disclosure, you and I have had some conversation, and I alerted you to the work that's being done by a group that I'm part of, a group that I would describe community elders. I'm sorry, I didn't introduce myself. I'm Ron Roseness. I'm a community health activist, and I'm here with fellow community activist John McCullough, others who are perhaps not in the room today, including Darian Taylor and Bob Leahy and John Maxwell from ACT. And collectively, we have many, many years of working together in community. Jeff Potts, also of CPPN, is in the room. Jeff? So a group of us have also been meeting and have, I think, really put ourselves on the same page and realize the importance of raising our activist voices collectively to really help move this forward. So I just want to publicly commit our group to helping to be part of the solution. But by the same token, I want to remind you at the same time that there are committees and groups forming, and we want to be part of it. We want to ensure that the successes that we've always had since the early days of the epidemic that have been entirely dependent on the voices of people living with HIV continue to be heard at this moment in time, when, as you clearly point out, there are all these things that we can be doing together. And I know we're on the same page when it comes to talking about testing. I know we're on the same page when we talk about the importance also of ensuring that we're looking after gay men's sexual health, because historically, and our women allies agree with us, that we need to ensure that the people, men who have sex with men, who have borne the brunt of the epidemic historically, continue to do so, are very much a part of the solution. And we think that if we get it right and encourage models of testing and can close the gaps in the leaks in the cascade, that we will be able to really reduce incidence and slow the rate of the epidemic in all of our populations, each and every one of which is important to us. So please know that we are committed to helping and working with you, and also to reducing stigma as a very large and important part of this collective effort that we must now all commit to. Thank you.
Thanks, Ron. We have a question over here. Let's go. So, just as the microphone. Thank you, Ron, for their comments. Well said. Day one, guys.
Hi, my name is Jason Mercady. I'm with AIDS Saskatoon. And I really liked the slide where you had with the microphone and said people need to get back on the front page. And so my question is this: with the last round of federal cuts to pretty much cross country, like the sector's now gutted, I guess where was everybody's voice? Because we're seeing, like, organizations such as myself, CAHR, Canadian Legal Aid Society, we're having to take the brunt in the media, and we know that that's going to come back on us in the next funding cycle. So where is the researcher's voice in advocating for our funding? And I get that you can say that you've had private meetings with PIAC and you've talked to them in private and things like that, but really we don't see anything in the media. We know our neck's on the line going forward. And in Saskatchewan, that's a big issue for us. And so where are the researchers advocating for us?
Each and every one of you in this room is part of this. And I'm serious, if we band together and really get our voice heard, we can do this and address the concerns that you have. There's no other way. It's not going to happen without it, right? So this is the research community for Canada. We do fabulous work. It's up to all of us to say, are we signing on to this? Is it day one or not, guys? Really, I'm serious. I'm turning it back to everyone else here, because really it's not about me. I'm just a messenger right now. So it's to all of you. Any other questions? Naveed has one. Oh, sorry, please.
I have multiple questions.
Okay.
I'm both a researcher and someone who runs a community-based organization. I'm interested in seeing, in addition to the scale-up that's been welcomed as far as new research dollars, where will there be new community dollars? We still are operating at 2004 levels when it comes to the community effort that's federally funded. When we talk about elders, I want to know if there are Black and Indigenous elders. That word, elders, that word that is part of our cultures. I want to know that when we're talking about elders, we're talking about Black and Indigenous elders as well. When we're talking about who's bearing the brunt of this epidemic, we have a Canadian treatment cascade that does not break out Indigenous and Black communities. What are our numbers? I want to know who's falling out in that treatment cascade. Where's the gap between who's in treatment and who is virally suppressed? I think it's going to look very different when we break it out on the basis of race and on the basis of indigeneity. We need this evidence so that we can do that effective scale-up that you were talking about, Sean. That scale-up has to acknowledge these realities.
Thank you. We have one more minute for one or two questions. Just to make one small comment, I think we need to learn how to do things concurrently with this. We need to figure out how we leverage and we get the right people at the table, asking the right questions and making really good decisions about how to support those who need our efforts the most.
Hi.
My answer.
Cécile Tremblay from Montreal. It's sad to see that most people here are doubtful that we will reach the 2025 suggestion to end the epidemic. And I think most of us here in the room think that we should be able to do it if there were political will to do it. I think people are tired to see statements from PHAC, from the government, federal government, that says, oh yes, we're going to end the epidemic, and then there's no resources. There are simple things that we should advocate collectively. PrEP should be free. Free, no co-payment, no franchise, free. Scale-up should be funded. We're struggling to have our PrEP cohort funded in Montreal from any agencies. So how can we envision that we're going to end the epidemic by 2025 if it doesn't come from an envelope with money from the government to fund all these groups that already spoke out, but also biomedical prevention and all the other things that the science, the evidence tells us that we should be needed. So we need to have a voice that not only meets with the government, but ask them for money. Money.
Well said. Sorry, oh. Thank you, Cecile. The government, by the way, as the microphone's going over there, is only going to do what it's doing. We need to put pressure. We need to step up. Actually, the ball's in our court, guys. Really.
Good morning, bonjour tout le monde. Je m'appelle Chantal Mukandoli. My name is Chantal Mukandoli. I come from Toronto. My question is this, because I need to clarify and then to give this feedback in my community, especially the people who don't understand science. So my question is this. I saw, Sean, your presentation, you talk 90-90-90. What about 10-10-10? I needed to know what we explain about where is 10-10-10 and scientifically, especially for people living with HIV. Thank you.
Great question, and we struggle with that and how to frame it. It is those people who need it most that we need to be paying attention to. You're very much correct, and we need to flip that because the health system's actually doing a pretty good job with getting people, supporting people in care. So There are still gaps, but it's doing generally a better job than we're doing in other areas. And it's those people who are falling through the cracks and not staying retained in care because we don't figure out how to support not just them in the clinics, but the other things that actually are important for their health and their well-being. So, point very well taken. I'm over time. Thank you very much for your attention, and have a wonderful conference.
Thank you, Sean.
Thank you so
Thank
much.
you, Sean, and this is